In terms of the practice guideline issued by the American Academy of Neurology, supported by the American Congress on Rehabilitative Medicine and the American National Institutes on Disabilities, Impairments and Rehabilitation, whatever it's actually called, is the focus is recommendations have now been issued that have been accepted by most of the surgical domains internationally. Ironically, in South Africa, this research paper has not made light of day or major media as yet. It is published in the International Neurology Journal. It is referenced by the American Academy of Neurology in formal guidelines, but I've yet to see any detailed discussion prior to this. And therefore, the intention of this is to very briefly traverse the recommendations in those findings in the guidelines provided. The first guideline is that clinicians should treat confounding or complicating other issues related to the patient's depth of consciousness or loss of consciousness during that period in which they are not optimally functioning. There should also be optimal serialized testing so that regular tests are being done to ascertain the depth of consciousness and the level of functionality. In my understanding of the process is there are usually 1 or 2 sets of tests being done, and that becomes the primary diagnostics of saying we've looked and that's the end of the conversation. The patient is potentially brain dead or in a coma. Serial testing is critical, and serial testing requires the use for both adults and kids. The latest updated testing modalities available to clinicians. Clinicians should also counsel families on the changes on what is known as the vegetative state, so what some used to call to date the permanent vegetative state, or the unresponsive states of the patient, and explain to the families the details of the etiology and how that may impact, or the cause of the injury or the circumstance, how that may impact the prognosis or the long-term outcome. The reality is quite simple. According to the findings in the practice guidelines on the multi-center studies, they have found that a lot of people may not appreciate as yet, that traumatic injuries have a better outcome than non-traumatic injuries, because traumatic injuries are a direct, immediate insult that's unexpected to the brain and the neurological system, as opposed to the slower progressive systems that cause changes of consciousness that are not of a traumatic cause. When the clinical team believes the prognosis is poor, there is an implicit obligation on the lead clinician on the team to inform the family that a poor prognosis at a moment in time is not a permanent poor prognosis, because the prognosis may vary, it may change and evolve with time. There is an implicit both ethical and clinical duty to inform the families of such opinions. Detailed MRI assessments by the clinical team, supported by specialized radiologists, are necessary. So it's not just a CAT or CT scan. In terms of diagnostics of these patients for ascertaining prognosis, there needs to be active efforts by the clinicians to inform the patients that they have the options of various modalities that need to be implemented. For example, specialized structural MRIs, which include susceptibility-weighted imaging, diffusion-weighted imaging, so detailed analyses can be done to look for bleeds on the brain, diffusion-weighted imaging to look for axonal injuries in the brain. Then there should be the consideration of the SPECT, or the specific or single positron emission computer tomography scan, otherwise commonly known as the SPECT scan, which gives a detailed analysis of brain tissue and its current state when the scan is done. One needs to then also consider the Coma recovery scale revised, which is a comprehensively detailed test modality that has been in practice internationally, ironically not actively in South Africa, to make sure that the patient is regularly assessed. In the medical legal space, regrettably, opinions are expressed utilizing the simplistic Glasgow Coma scale for long-term prognoses, but no assessment is being done with the Coma recovery scale to do a detailed assessment of where the patient is. These recommendations, again, are strongly emphasized in my understanding. Pain and the signs and symptoms of pain need to be actively and urgently addressed so that the clinical team can remove all levels of distress and discomfort for the patient whilst they focus on the patient's ongoing care and dealing with the prognostic discussions. It is recommended that the clinicians also prescribe amantadine 1 to 200 milligrams twice a day to improve functional recovery for the patient and reduce impairments and disabilities in the early stages of the recovery, because it's been documented and shown that it can create a massive positive impact if utilized timeously and actively. There's also the recommendation that family counseling sessions should be truthful and ethical enough to state that the natural history of the injury, the process of treatment, and the prognostics are not always consistent with the outcome. There are massive opportunities to consider for potential recovery and variations in the prognosis. It is also recommended that clinicians have a duty, and strongly an ethical one, that during their family counseling sessions for children who have sustained injuries or varying degrees of or levels of consciousness, is that the natural history of the injury, the prognosis, and the treatment have not been established to point to a particular prognostic outcome, which clearly demonstrates there are large variabilities, and it is not only a fixed outcome. And finally, the recent evidence points very specifically to replace the commonly accepted term of permanent or persistent vegetative state to a chronic vegetative state with a period specified. That simply points to there is no finality in the diagnosis. There is no finality on permanent brain injury. There is no finality because one has to appreciate the dynamics of brain tissue. One needs to appreciate the dynamics of the plasticity of the brain, irrelevant of whether it's children or adults, and appreciate that the evidence points that the GCS is not a diagnostic tool for long-term prognostic outcome. Not any individual test can be seen as a final prognostic value. The reality is, with the evolution of medical science, the art of medical science and medical diagnostics and processes, the prognostics are constantly evolving and changing. Thank you so much for watching our content, and we hope you're finding great value in the time and effort we're putting into this to share a very complex field of the medical legal world. If you do enjoy our content, we'd really appreciate if you subscribe to our channel, clicking on the button below and clicking on the little notification bell right next to that, so you don't miss the latest content as soon as it comes out. Again, if you like our content, we'd really appreciate it if you also liked this video. Thank you.